Hi, I'm happy that you've chosen to listen to my presentation today. I'm Ashley Long, and I'm the Concussion Clinic Coordinator at Mount Olive Family Medicine Center in Mount Olive, North Carolina. Mount Olive Family Medicine is a state-designated rural health center, and so my presentation today is going to be about athletic trainers in the rural community. This is the first part of a two-part series, and I'm focusing today on equal access to quality care. I have a few objectives for us, but first I'd like to say I have no financial interest or conflict of interest to report for this presentation. Our objectives today, as we talk about rural healthcare and the integration of athletic trainers into that care, is first to see which government agencies are involved in classifying areas as rural or not. Second, to look at the challenges that are unique to rural areas. Third is to look at the opportunities that exist for athletic trainers to help with healthcare in rural areas. And fifth is to really examine the social determinants of health and how those intersect with our rural patients, and again, look at how athletic training as a profession can help address some of those health issues that are specific to the rural population. So with that being said, I want to tell you a little bit about where I live. I'll try to have a global concept today of rural healthcare, but I think it helps if you know the perspective that I'm coming from. So you can see on the map here, the blue star is where Mount Olive is. This is in the eastern part of North Carolina, and we are classified as a rural county. And we sit right on the border with another rural county. There's lots of farming and agriculture in this part of the state. You can see the red stars are our major metropolitan areas. So we're in proximity, and about equal proximity, to Raleigh, which is our state capital, and Wilmington, which does have a significant healthcare community. And then Charlotte would be the furthest west, and that's the largest city in North Carolina. So if we're talking about the population of our state, we know that many barriers exist for the eastern part of our state. It tends to have the highest levels of poverty and the lowest access to healthcare. So I've lived here a little under 10 years and have experienced this firsthand. And as an athletic trainer and a healthcare professional, the context of the place where I live becomes very important as I discovered the path forward. Most athletic trainers are familiar with the Atlas put out by the Corey Stringer Institute, and this is a great tool for us to use as we start looking for schools that have athletic trainers and what the availability of those athletic trainers is at the school. As I've served on various committees with other healthcare providers, specifically physicians or healthcare administrators, I try to spread the word about Atlas because this can be a great tool for them to see what are the resources that are actually out in our community when we're talking about adolescent athletes. So, for example, if you have a primary care physician who may be taking care of injuries such as concussions, they may need to know, do I have that healthcare provider, the athletic trainer who's out at the school and can be my partner in care? And so the Atlas can be a great resource for them. In my case, when I moved to the area, being an athletic trainer, I just thought, okay, well, let's see where my colleagues are. And as you can see within the red circle, there are very few athletic trainers at the high schools within about 30 to 40 miles of where I live. And so I saw this as an opportunity to increase the availability of our services And as we go through the presentation, I'll show you in light of the circumstances of the rural nature of Eastern North Carolina where we are. The government pays a considerable amount of attention to if areas and certain populations are designated as rural. Now, there's actually two agencies within the federal government that make those specific designations. So one is the Census Bureau, and the Census Bureau is a great resource for information for athletic trainers and healthcare administrators as we're trying to determine population data as well as information about rural health. So again, the federal government uses two major definitions. One is produced by the Census Bureau. The other is produced by the Office of Management and Budget. Now, both of those use different criteria to classify if something is rural or not. The Health Resources and Services Administration, or HRSA, is going to use parts of both of those agencies' definitions. So again, the Census Bureau and the Office of Management and Budget both make their own designations of what is classified as rural, and then HRSA is going to take an adaptation from both of those. HRSA, it becomes very important and is sort of the lead on when we're looking at what is rural, what is considered rural when we're talking about healthcare. Now, with the US Census, some would argue that they tend to overcount the population that is rural. So some would say that part of their classification of rural is really technically suburban. So we tend to have an overcount with the US Census. The Office of Management and Budget, some would say, tends to undercount or underscore the areas that are rural. And so hopefully with using both systems, HRSA is kind of getting their finger exactly on the pulse of where our rural population is. Now, CMS, the Centers for Medicare and Medicaid Services, do a great job at looking at healthcare for the entire population of the country and who may be at a disadvantage for this healthcare. So CMS has specific equity initiatives, and one of these equity initiatives is with rural health. And they have developed in 2018 a rural health strategy. And really what this strategy is a proactive approach on healthcare issues that are specific to those people that live in rural America. A lot of this is about access to quality care and also about affordability. We'll talk later in the slide about what are some social determinants of health, what exists in the rural population, and how is CMS trying to address those specific strategies. CMS, in their rural health strategy, has actually 5 components laid out. One is supply a rural lens to CMS programs and policies. And so an example of this that I can think of from my own clinical experience and professional experience is working with colleagues on a national call and them maybe making some assumptions about resources that would be easy for patients to access, but me living in the rural area, knowing that, you know, what they're saying may be simple for their patients would not be simple for mine. And so I think CMS is really trying to, with the rural initiative, is trying to make sure that they're always considering, well, how does this look for the person that's designated as rural? The second strategy that they're trying to employ is to improve access to care through provider engagement and provider support. And the good news about this is that they have funding available that allows healthcare entities to tap into resources that will help their providers provide access to patients. And so that's something that we've taken advantage of at our rural health center, and something I'll describe in detail. Another major initiative that's under the rural health strategy is an advance in telehealth and telemedicine. And lots of us have been hearing a lot about this. There's some great examples of physicians, athletic trainers working together, specifically with concussion. And there may be others out there where they're using that telehealth and telemedicine in the rural application to get that access to people that either have transportation barriers or the distance is just too far to travel. So telehealth and telemedicine is definitely coming down the pipeline, and we hear a lot about it in the context of rural patients. They also want to make sure that they're empowering patients in rural communities to make decisions about their own health care, and they have various initiatives to address this. The last strategy that they're employing is to leverage partnerships to achieve goals through the CMS Rural Health Strategy. And so we see connections and bridges being built with the objective of helping the rural patient. Some colleagues and I did research several years ago, and this is specific to the state of North Carolina, but we found some things to be very interesting. We surveyed, at the time there were exactly 400 public, or I should say high schools that participated in the North Carolina High School Athletic Association, so our state governing body for athletics. And we made a phone call to every one of those schools to ask if they had an athletic trainer, if that person was there multiple seasons for multiple sports, which we designated as being full-time, and who was employing that person. And if they didn't have an athletic trainer, our state body designates a first responder and makes a definition for that. So the rule is that you have to have a first responder who's somebody certified in CPR and first aid and has 10 hours of education through our high school athletic association. And this determination, or this first responder, would have to be present at all football games and practices and any wrestling competition. So that's just happens to be the rule for our state. And we're interested in how many athletic trainers are out there. Are they full-time? And what we found, and we did some regression models to see, well, what would predict if someone had an athletic trainer at their high school, particularly a full-time licensed athletic trainer. And we looked at various predictors or variables, such as Title I status, which is that federal designation for a large percentage of low-income students. And we found that Title I status for the school in North Carolina was not a predictor of full-time athletic trainer in the high school. But we did find that when we looked at the economic health of the county, that the Tier 1 counties that are the most distressed, the least economically viable, that became a significant predictor of not having an athletic trainer, full-time athletic trainer. Whereas the Tier 3 counties, as you can see on the table there, the least distressed counties had a great rate of full-time athletic trainers, and it was very strong predictor that they would have one. So that economic health, in this case, we didn't necessarily look at the rural health designation, but we did look at the economic health, and there's lots of crossover between those two, also with our most healthy economic counties being our metropolitan counties. So we're kind of seeing the economic variables as a driver of that access to athletic training. From my own experience, I could see that the further east we went, the more rural, the further away from the metropolitan areas, the less likely I was to encounter an athletic trainer at a high school. We're not the only researchers that have published data about athletic trainers in high schools. There's others that have published great studies looking at this. For example, we see here in the study that's from Clinical Journal of Sports Medicine that schools with an athletic trainer on staff were significantly more likely to be in an urban location, so similar to our findings, have an enrollment of 1,000 students or more, so well-populated high schools, and have a smaller proportion of students eligible for free or reduced lunch. And so although we did not find that Title I data to be significant, this study did. So they saw, if the school had a higher income population, a larger population, and was urban, they were much more likely to have that athletic trainer on staff. So we can see from a healthcare access and equity perspective that the children who are likely more advantaged in the first place concerning healthcare also are more likely to have the athletic trainer. And as we look at, from a population health perspective, the people that really need the athletic trainer are much less likely to have one. And so what we do at Mount Olive Family Medicine is try to increase the access to care, not necessarily through full-time athletic trainer services, although that is hopefully in the future for us, but at least through our concussion program. So most of the schools that we serve do not have a full-time athletic trainer or an athletic trainer at all. Because we run a concussion clinic, that injury becomes, important to us as a metric, and looking at, what happens at the schools without athletic trainers concerning the specific injury of concussion. And McCrae and colleagues published a study also in Clinical Journal of Sports Medicine showing that concussions are most frequently reported to an athletic trainer, and that teams at schools with an athletic trainer had a significantly greater number of diagnosed concussions. So we always joke, of course, the athletic trainer isn't imposing concussions on the patients, but that they are actually there to identify the patients with concussions. I can speak anecdotally on this. I work closely with approximately 20 high schools to provide baseline testing for their athletes and then to treat them in the clinic after concussion. And one of the very few athletic trainers that I work with that's at a school that's actually the furthest distance from our clinic in our first year was our number one referral source. So we saw the most patients in our clinic from the high school that was furthest away. But this was one of the only high schools that we had a partnership with that had an athletic trainer. So I got to see this research actually play out in our clinic, where we could see that because the athletic trainer was there, they were diagnosing the concussion, identifying it, finding resources for that patient, and getting them to appropriate care. Now, the NATA had put out a logo or a saying, athletic trainers are healthcare. And I think, we've seen our profession really grow to embrace our role that we play in healthcare. And when we look at healthcare from a social perspective, we can really see how athletic trainers can help address and intervene on a level at the social determinants of health. So Healthy People 2020 put out an approach to how we were going to identify and address the social determinants of health. So those are categorized as neighborhood and built environment, health and healthcare, social and community context, education, and economic stability. So these are categories that contribute to the social determinants of health and have been shown through research to predict and affect the health outcomes of patients. So I want to talk about each one of those. First, economic stability. And so you can see the components listed on the slide. The one that I'd like to mention is poverty. So this is a measure that you can obtain through the school systems if you're dealing with adolescents in your local schools. I had mentioned earlier the Title I status of schools. Title I school is a determination that is made about the income level of students and the percentage of what is determined to be low income students at a school. And so and there's different levels within Title I. So you can have a school-wide Title I program, and an example of that might be free and reduced lunch is available for every single student at the school. Now, not every student at the school may be him or herself low income, but because there is a high percentage of low income, they'll make the program school-wide. So any of the federal funding that's given to the school is available for all the students. Schools with lower percentages of low-income students, but still a significant percentage, and I believe that's about 45 to 65%, they might have a partial program where their money is only going to the students that they themselves are low income. So the free and reduced lunch might be available, but it's only available for those students who qualify and not the other students as well. So when you see a school-wide Title I program, you can be assured that there is a large percentage of students in that school that are qualified as low income. Other components under economic stability are going to be employment, food insecurity, and housing instability. As we go through onto the next one, education. So we look at things such as high school graduation rate, what percentage of individuals have a degree in higher education, whether that be associates, bachelor's, or master's and higher. Language and literacy. So in many rural areas, we may have an influx of immigrants whose first language is not English. And so this becomes a component of their ability to access healthcare and the provider's ability to communicate that with a patient. Social and community context. So we look at things like incarceration rates, discrimination, civic participation, social cohesion. And so we can, it has been determined that rates of, let's say, incarceration can have a negative impact on the health outcomes of the person, but also their families. Discrimination is another, and we'll talk about racial discrimination in the latter part of the presentation. Health and healthcare, so access to primary care and then access to healthcare in general, along with health literacy. So people's basic knowledge about healthy behaviors, immunizations, things that we know can prevent the spread of disease or the severity of disease. And finally, neighborhood and built environment. So we look at things like crime and violence, obviously those having direct implications on health, access to foods that support healthy eating patterns. So we hear more and more about things such as food deserts and programs aimed at bringing fresh and healthy foods to individuals that don't have easy access to them. Also looking at the quality of housing and environmental conditions. So when you have a high percentage of people not owning their own home but renting, they can be exposed to poor living conditions that may be outside of what they can control. And so we take this into consideration when we're looking at that aspect of the social determinants of health. As I developed our program here in conjunction with the North Carolina Department of Health and Human Services Office of Rural Health, I had to develop a proposal. And a lot of the data that I used and data in this presentation, I extracted from the US Census Bureau. And so you can see here a screenshot where any of you could go if you're looking to support an initiative. And you can enter your state, your zip code, and you can look up different demographic variables of the citizens in that geographic area. And again, when it comes to making a proposal or an argument, data is going to be very important. And so this was a very useful tool for me as we built our program, and could be for you as you may be making a proposal either for funding or for expanding your program. When I was making proposals for why Wayne and Duplin, Lenore and Sampson needed greater access to care for concussions, I utilized data from the US Census Bureau. And what I did, and in this particular graph, you can see the first 4 counties that I've listed are counties that I serve. And then Orange County is going to be where Chapel Hill is, just to give a little bit of a contrast. And then Wake County is where Raleigh is, and Wake County is, houses the capital of the state. And so when we look at total population, you can see, pretty dramatic difference in the metropolitan area versus these rural counties. And even just thinking from a business perspective, if you own any business, but a healthcare business as well, your better strategy is to locate yourself where there's going to be more people. And so that naturally happens through, our free economy. And so a lot of people do not choose to house their businesses or healthcare entities in the more rural populations. I also chose to look at racial composition by county. So this does fall under the social and community context of our social determinants of health. Again, Wayne County is the county that we're housed in, and it borders on Duplin County. You can see that in all the counties, the greatest population is of whites. But then when you look between Blacks and Hispanics, that changes. For example, in Duplin County, we see a large population of Hispanics almost reaching the same level of Blacks. And so in Duplin County, we have many people that English is not their first spoken language. And we take this into account when we're dealing with or helping treat patients in Duplin County. And an example of something that was important to our program was access to a translator. Then you can see in other counties, like for example, Lenore County, we have the largest percentage of persons that identify as Black. And we'll talk about why we do consider race when we look at social determinants of health. And we can see that racial data and ethnic disparities do exist in healthcare. And this contrast is so great that CMS has an Office of Minority Health. So they designate an entire sector to addressing minority health issues. So racial, ethnic, and gender disparities that exist in healthcare, and they're looking specifically at Medicare, but we want to see, with the differences in races, what are the differences in healthcare outcomes? And we know that on most measures that there is a great disparity in race. And so part of our program measures that we take, whether it be baseline or within the clinic, is the race of our patient, because we want to show that we are providing access to groups that traditionally have poor patient outcomes and lower access to healthcare. We also want to show a sensitivity to the differences in whether that be from a historical context or from a cultural context today, of how different races approach healthcare and what their perceptions are, and also being sensitive to having access to providers with whom they can identify. So the racial data is important to us. As far as an example from our neighborhood and built environment social determinant, the food insecurity rate as a percent of the population becomes a good measure for us to understand what our patients are truly dealing with. So when we say food insecurity, the USDA defines this as a socioeconomic condition of limited or uncertain access to enough food to support a healthy lifestyle. There are many students in the schools that we serve that receive bags of food on Fridays to take home with them so that they can have greater assurance that they will have something to eat over the weekend until they get back to school on Monday, at which they're given 2 meals for free. And, as we as providers are looking at our patients and the obstacles that they have, how nutrition affects their healing, and the bandwidth that they have to enact the things that we might prescribe, we have to consider what the barriers are to their basic human needs. And food insecurity is one of the things that we consider. Within our clinic, we make direct access to other resources within the community that can help with issues such as food insecurity. And so we're practicing in a more suburban, higher economic population. This might not be a consideration. When we're working with rural patients, we have to consider these things. So we can see in the counties that I serve, over 15% of the population has food insecurity. And so that, differs compared to, Orange and Wake County, more metropolitan counties that, don't exceed that 15% mark. So again, that can change the way that you're looking at your patient, things that you're considering when you're applying their care, and resources that you might want to connect with to make available for them. Another great measure that's used in a lot of grant agencies or grant application eligibility criteria is the health professional shortage areas. So this is a determination by Health and Human Services. Again, I have North Carolina on here just to put it in context with our clinic. But you can see that they look at access to primary care and access to mental health availability. So this map actually shows the access to primary care. And you can see, for example, with Wake County, where Raleigh is, that this does not have a health professional shortage, but that as we go further east, as I described earlier, we see a lot greater scores to that HPSA score. And of course, the darker is, the less access that people have, or the greater that the shortage is in the area. So although we don't want a shortage anywhere, if you're living in a place where there is a health professional shortage area, this may qualify you for applying for certain funds that go to address those provider shortage areas. And so within the red circle, again, are the main counties that we serve, Wayne, Duplin, Lenoir, and Sampson, all four of which are professional shortage areas. A clinical perspective on this would be my colleague that was the athletic trainer at the school that was furthest from us could not find a primary care provider for some of his patients who would see them if they had a concussion. And so that problem would be much less likely in a more metropolitan area, but that's what he was coming up against. And so he and I developed a relationship, me in a primary care office with concussion clinic embedded into it. And there have been occasions where we end up becoming somebody's primary care provider because they cannot find somebody otherwise. Another really important factor is going to be health insurance. So of course we hear all of this on the news. In North Carolina, we were a state that did not choose to expand Medicaid. From a political perspective, we just recently passed a budget that should have been passed in March, and a large reason that it was held up in our state legislature was over the expansion of Medicaid. So clearly a very large issue politically and for our country, but also plays out at the state level. When we look at individuals with health insurance, most are going to receive that from an employer. And then if you're under a certain threshold, you're eligible for Medicaid if you're under 65, or Medicare if you're over 65. But there is a certain population of people, which for the first time in I think over a decade is now beginning to grow, that is uninsured. And so these people we take particular note of, because obviously being uninsured is going to have a very large impact on the accessibility that you have to healthcare. So within the first 4 counties listed there, these are rural counties, you can see that they have the highest percentages of persons without health insurance. And in Duplin, almost reaching 20%, that would be 1 in 5 individuals with no health insurance, compared to about 10% in our more metropolitan counties. If we're thinking about athletic trainers in different settings, think about the athletic trainer at the high school and the potential that they could provide to students without healthcare insurance. And, talking to colleagues over the years and watching this play out with my colleagues who do work in rural settings, a lot of times this athletic trainer is the primary point of healthcare for these students. And I think, our profession needs to continue to measure that and present that to either, grant making agencies or policy making agencies as we show the value of school-based healthcare for these individuals. We do provide access to care. We do not turn away people without insurance. And there are ways that we can work with these individuals to be able to continue to have access to our care, even without them having health insurance. Many providers do not even see patients with Medicare or Medicaid, let alone a patient that's uninsured. And so as most of us realize, a lot of those individuals end up at the emergency room. So there is a stopgap that we provide by seeing those patients. And then through the availability of the grant funding, we can absorb that cost. As we look at the percentage of persons in poverty, you can see that some of the counties we serve are close to 25%, but all are over 20%. And, you know, poverty is a general term that we use a lot, but I think it's easy to forget what poverty actually means. And so for a family of four, poverty means an income level of less than $24,000 a year. So to put that in context, you know, lots of our graduate assistants may be making, you know, close to that amount of money, or certainly are they themselves are at that guideline. But for a family of four to bring in less than $25,000 a year, that is qualifying them as in poverty. But I think we could all agree that a family of four making $30,000 a year certainly is going to come up with a lot of barriers. So I put this slide in just to remind you how high the measure is to be considered impoverished, and that there's a lot of people that don't meet that very stringent measure of poverty that then don't qualify for a lot of the programs that we have. And so again, those people that kind of fall through the cracks in the middle are important people that we can serve, but also realizing that about 1 in 4, 1 in 5 individuals within our rural footprint are considered to be living in poverty. And that's a huge social determinant of health. Economic stability. So again, that measure of the poverty rate, you can see on the map here, another reflection of how many are living in poverty and where those tend to cluster. So this is specific to my state, but all of this information is available to you through the US Census Bureau for your state, and can be very important visual and graphic data as you present to people if you're trying to either grow your footprint or gain access to money to help support the work that you're doing. Now, Mount Olive, where I live, was recently named the poorest town in the state of North Carolina. And as you've seen through the maps, Eastern North Carolina contains some of the poorest counties in the state. For our footprint, over 90% of the schools are Title I. And so when I first moved here, gathering all this data was very important as we sought grant funding to be able to support an athletic trainer run concussion clinic. And so you can see some of the data there about Wayne and Duplin counties where we serve, but we have very high percentages of low-income students in Title I schools. So I extracted this data specifically from our Department of Public Instruction, which is another great source that you can use when you're looking for percentages of low-income students or Title I data that's specific to the schools that you're serving. We also see that income inequality is growing as well. So that's a point to note. When we look at education, this is another one of our social determinants of health. Looking at the percent of people with a bachelor's degree or higher. So these numbers are more striking than some of our other measures that we take. So we see in Wake County, which is where Raleigh is, that over half of individuals have a bachelor's degree, whereas in the counties that we serve, under 20%, and in some cases only 10%, or 1 in 10 individuals have a bachelor's degree. And so, we know the downstream effect of gaining access to education, whether it's in the way we educate our patients and their abilities to understand concepts or have context to refer concepts to, or if it's in their employment and their income opportunities. So obviously education affects lots of different things and can be a very good determinant of someone's upward mobility. And when we see these disparities between our rural counties and our more metropolitan, it really accents not only the opportunities that exist for people that live there, but also the way that we educate and approach our patients and families. So that was, those were some examples of the social determinants of health, but what I hope that you can see is that in a rural community, all of these social determinants of health tend to be affected, and they get compounded on one another when we consider how far away things are, the low income levels. And so we kind of create this perfect storm in our rural communities of the social determinants of health piling on one another. So as we developed this clinic, what our objective was is that we wanted to create an equal access to quality care. And so I approached Dr. Talton, who's pictured on the screen, to see if we could begin a concussion clinic. Sometimes there are many things that need to happen, and you have to start with the first step. And so that was where we began. And with our partnership, we had access to money through the Office of Rural Health and our State Department of Health and Human Services. And so because Mount Olive Family Medicine is a state designated rural health center, they have eligibility to apply for different funds. And that Office of Rural Health gives out grants such as innovation grants, which was the grant that we got in our first year, and then community grants, which is the grant that's currently supporting our program. This supports the salary for athletic trainers to run the concussion clinic, and it also supports the technology and personnel that run the office and support the program. So it allows us to baseline test out in about 30 schools regionally, and then to see patients no matter their insurance status for care for their concussion. Many states do it many different ways, but our Office of Rural Health has 17 sites at which they designate as a rural health center. And so again, that gives those centers, and the one that's circled is where we are, Mount Olive Family, access to resources and funding that helps their clinic operate. Ours is a nonprofit clinic, which is a different model. We do have fee for service, and we have to generate the money that keeps us running. So it isn't a free ride, so to speak, where the government is just supplying it and ad nauseum. We do have to keep the lights on and generate the revenue for that, but it's also not a for-profit corporation. And so that dynamic, I think, frees up the mindset of service. And with our profession, this is often where we're coming from. How can we increase access to care for our patients and increase the quality? That's the mission and values of our center, which allowed me to align athletic training nicely with that philosophy. So talking a little bit about the patients we see in our clinic and the schools that we serve. Now, this is some data from our first year of the concussion clinic. Most patients came from the county that we're in, or the county that we bordered, but we did draw some patients in from far away. Again, that Lenore County, we only went to one school in that county, but that was the county that had an athletic trainer. And so that sort of reflects some of that research we went over in the beginning about having an athletic trainer and how that's going to increase access to care, in this case for concussions. We attempted to track the referral sources of the patients in the clinic. And so first responder, that designation from our high school athletic association, was the #1 or the highest referral source, or the person who's kind of navigating the patient toward us. And that makes sense because that is the, I'd say about 90% of our schools are staffed by that first responder. Now, not too far behind that's the athletic trainer. And during this year, we only had one athletic trainer at a school. And so, again, we're seeing that kind of high. School nurses have been great partners. Many of you know this already. I had worked mostly in the collegiate setting rather than secondary school, and so was really amazed and pleasantly surprised at the relationship that I built with the school nurse. Most of our schools do not have a team physician. I've lived in metropolitan areas where different organizations are vying for that and jockeying for that position on the sideline, the ability to hang their sign on the fence, the ability to come have access to the students. The dynamic, in my experience, is very different in a rural setting. Lots of providers are very overwhelmed with the volume of patients that they have to see. And therefore, the spirit of competition and of business is much more muted in the rural setting. Again, they're kind of doing all they can in the clinic and not looking for more people to come through the door. And so that dynamic's different in the rural setting. And just in my observation, that really plays out in the ability for schools to find physicians to volunteer to play that role. We also did have some referrals from emergency departments, and I'm guessing, that may come from individuals not having a primary care, and, the physicians in the emergency department realizing that the child's going to need some follow-up care after their ED visit. In North Carolina, Blue Cross and Blue Shield of North Carolina is by far the largest private insurance company. I think some of the statistics I've heard is over 80% of they capture over 80% of the private insurance market. So it's no surprise that they were our #1 insurance provider of our patients. But second to that was Medicaid. So we see Medicaid patients as well. TRICARE, which is through the government. So our county houses an Air Force base, and we developed a relationship with providers on the base who gladly authorize us to see the concussion patients to provide the extended care that's needed for them. We also saw, other private payers as well as self-pay and Veterans Affairs. When we think about our vision to the future, it always surrounds that equal access to healthcare, which is one of those initiatives through the Office of Rural Health. And we want these student athletes in the health provider shortage areas to have that equal access to the standard of care for concussion, which is a multidimensional assessment. And that's what we're trying to provide, regardless of where somebody lives, their ability to pay, transportation, and everything else. We really try to make it as accessible to patients as possible. We want our professionals, our athletic trainers and physicians to be up to date and using evidence-based practice. We also do quite a bit of education in the community to other providers so that we can spread that knowledge around. Again, it's not a competitive atmosphere, it's a very collaborative atmosphere, which is part of the joy that I've found in practicing in a rural setting. We want our patients to have access to quick appointments. This, in my experience, is a large barrier for many students with concussion, is the ability to have an appointment. Many having to wait over 2 weeks to see their provider. And we know how important that initial education piece is with cognitive rest and otherwise. And we want to make sure that their trajectory is normal and there's no special intervention that's needed. And so that initial visit becomes very important in a timely manner. We also want to provide care and advocacy through the return to learn and return to play processes. This has been a large portion of what I do, is advocating for the patient within the school. Since they don't have an athletic trainer there, I've developed relationships with school counselors and nurses to make sure that the patient has an adult advocate when it comes especially to their return to learn process, and that they aren't, and that they're being abided by. And also we do quick and appropriate referrals to specialists when necessary. So for example, we screen for vestibulo-ocular dysfunction. And if that's not resolving with someone, we get them a referral to physical therapy in a timely manner, or to a clinic that addresses those dysfunctions and can correct them. Otherwise, hopefully avoiding a protracted recovery. And, those types of observations during an assessment take time and skill. And so we try to provide that to the community that did not have that before. What we see in the future is hopefully some integration with telemedicine, more partners and providers with clinics, and expanding the staff and the reach of what our clinic can do. So the interest in the clinic has grown. The number of patients that we've seen has almost doubled in the past year, and we continue to be able to show value. We also generate revenue when the patients come into the clinic, and also have educated providers, parents, coaches, and community members about proper concussion care. So I hope that today we've met our objectives in talking about how we classify rural health areas, the different government agencies that measure that, challenges, and along with social determinants of health that are specific to our rural patient populations, opportunities that exist for grant funding and otherwise, as an example through our clinic that we took advantage of, and that you can walk away either able to advocate for your rural patients in a better way, see opportunities that exist for serving this patient population, and a greater understanding of the obstacles that exist for rural health patients when you're treating those patients. It's been my pleasure to give this presentation, and I want to thank you for listening.